Hi, everybody. This is Karen Anderson here with Aortic Hope, and I'd like to welcome you all to our live Q&A. Before we even get started, I want to say happy Veterans Day. Thank you so much to our veterans that are out there. We just want you to know that we're thinking of you and we appreciate all that you have done and you do for our country. We want to get started tonight with a very special guest. We've had her on before. I'm going to let her self-introduce, but this is Dr. Stacy Fisher. Why don't you tell everybody a little bit about yourself?
Sure. Thank you so much. It's so much fun to join you. This group is so special, spectacular, actually. And I love being here. Please feel free to ask any questions. They don't have to be related to the topic. And I am going to stick in one of my own topics. But I'm the Associate Director of Adult Congenital Heart Disease for Johns Hopkins. I am the Fellowship Director for Adult Congenital Heart Disease. I do a lot of genetic counseling, treatment, testing, assessments, and aortic assessments. Also, I have an interest in 3D printing and trying to make surgery safer, procedures safer for printing. This really started with congenital heart disease, looking at how to make surgery safer. And we have been working a little bit with aortas, trying to make aortic interventions safer. And right now, this is most helpful in some of the catheter-based technologies or revision procedures. But I brought a couple of models to show, which when Karen says it's a good time, we'll bring them out.
Okay, so our topic tonight's a little different because in the past, we've kind of just done aorta 101, blood pressure 101, pings and pangs, that terminology I know you love, and I'm sure we'll get to that before this afternoon is over. But I really wanted us to focus on genetics. We've never really talked about the top genes or mutations that exist that we find within the community. We know that they're out there, but we've never, at least Aortic Hope, delved into the specifics about some of the more common terminology. And I do have questions when we're done about some other inflammatory issues in genetic testing. So why don't we start with talking about the most common genetic issues that we would find that would create aortic disease or aneurysms or dissections. So what do you want to kick it off with? Which one do you want to go with first?
I think first of all, genes. Why genes? Why are we interested in genes? What are we going to get out of looking at genes? So just kind of the broad topic to start with. One of the big issues is why. So somebody may present with an aneurysm or dissection. It may be incidentally found, or it may be a frank emergency, or it may be that somebody had a death in a family. And an autopsy showed that they had had an aneurysm or dissection that was the cause. So why? Why would that develop in somebody? And there are a lot of reasons for that. Sometimes they're traumatic, car accident or an injury. Sometimes they are from atherosclerotic disease, where people have plaquing and distortion of their vessels, and then an aneurysm forms and there can be a tear around a plaque. But sometimes it just happens. And sometimes it happens in a young person where it's unexpected, where suddenly there's a change. And one of the big questions is why? How does it affect me? What other types of screening should I have? What other parts of my body could it affect? And who in my family could I actually protect by maybe knowing if they have a sensitivity to aneurysm or dissection? In other words, if their connective tissue is weaker, is there a problem where they could be injured more easily? And are there things we could do to prevent problems? The long-term hope of understanding genes is, what does that actual gene do? What proteins does it make? What part of the infrastructure or fabric of the tissues does it make? And of course, what could we do to alter that? So could we take a supplement that would improve that? Could we do something that would actually help that? And hopefully the research, as we understand these genes and the fabric of the tissues, will help us to know what else to look at, the associations a particular gene has, and also maybe make something that would actually allow strengthening of the fabric if there's a particular part that is missing or altered that makes it weak. So hopefully the research will actually translate to better care. So the first thing that we think of is there a clear explanation for why somebody had aneurysm or dissection. If that's the case, then we really don't need to do gene testing. If that's not the case, and we still don't know why, or is there a predisposition? Or, for example, there's an unusual family history where you're the third person that had an aneurysm found. We want to know why, and we want to try to protect the other people too. So a lot of times we'll start with a family screening, family history, who's been affected, who might have been affected. Was there someone with sudden death that was unexplained that might have been an aneurysm? Were there aneurysms in other parts of the body besides the chest, like the brain, the belly, a leg aneurysm, something, more unusual? So that can actually be really important in leading and trying to help us understand these things. And then certain genes affect not only the vessels, but other parts of the body. So for example, there's a fibrillin gene that causes Marfan syndrome. In Marfan syndrome, most people are taller than other people in their families. There can be flattening of the cheekbones, a very high palate, chest wall shape deformities, or changes with how straight the spine is. So there are other features and other tissues that might be affected. There might also be hernias that are part of that. So there are typical features where some people, it's so strong that you could look at that person and say, yes, you have this gene. But there are also times where somebody may not show all of the different features that can be expressed with a gene. So for example, if we find somebody has a gene change for fibrillin mutation, which causes Marfan syndrome, we are also going to want them to check their eyes, to look for hernias, to look for intracranial aneurysms, to do screening once a year for the belly, the vessels that go to the gut. And we're also going to look at their lungs because they're prone to things called a pneumothorax, or kind of popping of an air bubble that can hurt the lungs suddenly. So we look for other things. We try to use anticipatory screening and care to prevent emergencies based on the gene findings or the things it's associated with. So there are genes that have things that you could look at somebody and think maybe they have this, and there are genes where they don't really have anything different from anybody else, but their tissues are weaker.
Mm-hmm. Okay, so I love how you explained that there should be the how, what, where, who aspects to thinking about the genes. So if you're just somebody who never heard that they had a family history of Marfan or some of the other common names, vascular Ehlers-Danlos or Loeys-Dietz, and you have a dissection, so you're the first person in your family to have one, but not necessarily the first person to have had an aneurysm at some point in their aorta. What would be the first step you would tell somebody like that to take? I know you just explained some scenarios in which you would think, let's do genetic testing, but a lot of us come out of this and we just say, why? Why did this happen? I didn't have trauma. I wasn't in an accident. Maybe I had a little bit of high blood pressure, but nothing that was astronomical. And I considered myself relatively healthy. Now we all look at ourselves and say, were we really healthy? So all these questions come into our mind and we're not really too sure what to do, but we all want to know why. Why did it happen? It's just human nature, not much we can do about it after the fact. But what we could do is maybe help prevent our siblings or our children. And so that's where the why comes in for us as patients. So what would you recommend we do?
So definitely talk to your providers about it, number one, and look at other things that may or may not have shown up on the screenings. So for example, if you had an aortic screening, but also had abnormal vessels around the spine or blebs around the lungs or a chest shape change that you didn't appreciate before, there may be things on the screenings that you've already had that actually guide the testing. But in general, there are commercially available tests for gene testing that are available through companies, and they each have a panel that is available. So you can test for an individual gene. So for example, if I see someone who clearly has Marfan syndrome, we may just test the Marfan's genes.
Mm-hmm.
right? Or we can do what's called an aortopathy panel, where we do a broader look. And the broader look will look at the known genes, both that have features that you can see and ones that have features that you can't see, like the TGF genes, TGF beta genes. But we will do, a broader profile if we really have no idea why. And that the gene testing can be done with blood, or it can be done with saliva or a cheek swab, where we need to get enough cells from either salivary cells or gum or cheek cells or blood cells. But they extrapolate the DNA, and they actually look at the genes that we associate with these problems. We don't look at all the genes. This is not a whole gene test, at least not to start. So we can look at the genes, and we can look for changes that are known to cause problems in the matrix of the fabric of the vessels. So the possibilities of that testing change, and as you broaden the gene search, it's a little bit like fishing, right? So if you're fishing and you're fishing just for things you know of, right? So we're checking only the genes we know can cause problems. On those genes, is a lot of personalization. So you may have a gene change that is definitely causing the problem. And if
Okay.
you have that, say we check your genes and you have a gene that causes Loeys-Dietz syndrome, and it's pathologic for Loeys-Dietz syndrome, then we know that we need to screen the rest of your vessels. You may be the first one in your family that had that gene change, but you may have passed it on. So if you have children, it would be about 50-50 that each child would inherit it. And if you have a child that inherited it, they could also pass it down to their lineage. If you have a child that did not inherit it, that child's home free. Doesn't need screening. It's definitive. You're done. And again, if you've had brothers, sisters, parents tested, especially parents tested, you're going to know whether you're the first one in a generation or whether all the cousins need to get tested. Right.
And
so
is that
you
specific just to Loeys-Dietz, or that
no,
pertain to
no,
Marfan too?
just that any of the 50-50 dominant genes.
Okay.
But the other possibilities from doing this gene testing is you may do a broad panel and it may come out negative. Right. So that does not mean that you didn't have a dissection. It does not even mean that you don't have a gene change. It means that you don't have one that we knew to test for.
Okay.
So if you're in that category, then you've done it. You've spent the money on gene testing, which used to be unaffordable and is now very affordable. But you didn't find anything from it. So you went through, doing the test, waiting for the test, and you got nothing out of it. There are other steps that can be taken. So there are definitely whole exome gene tests that can be done that look at all of your genes. And there are also some research studies being done to try to look at different genes that we haven't understood well. Now, the third possibility of your commercial gene test is that you get something called a variant of unknown significance. And that's exactly what it sounds like. There is a spot on the gene that may be abnormal and causing the problem, or it may actually just be something that's interesting to you, but doesn't change the way the fabric is made and really has nothing to do with why you had your problem.
Okay.
So we try to kind of put those on the side, look at bigger databases, follow them, and reclassify them over time. So some of those will end up being absolutely fine. It didn't cause the problem. Some of those will actually come out saying it did cause the problem. Now that we know that this is pathologic, now we'll offer testing for your family. But we would not test the family for those spots unless we actually think they're pathologic, because again, it may be that that spot didn't matter. So you get your variant, your child has the variant, your child may or may not have anything different than anybody else, and that spot may or may not matter. We don't want to make decisions for your child based on that spot. We would make the same decisions for screening your child based on the fact that you had an aneurysm, but we don't want to include that at this point. Now, if you have a brother or sister or parent that also has an aneurysm or dissection, the gene companies will generally do free screening on them for the spot and other spots and try to reclassify this variant for you and for other people, right?
Okay.
So we're learning more and more, and as artificial intelligence um, software and processes start getting into the gene world, which they really are right now, we're
Hmm.
able to look at a lot more data more quickly, and we're going to expect to actually understand these genes and what happens from these genes more quickly. So we expect to have rapid progress in understanding these variants because of artificial intelligence software that's getting into medical research now, and
Hmm.
especially into genetics research. So it's a rapidly progressive, very, very exciting field opportunity pathway for students and research. So incredibly exciting.
I do have a question because this has been tossed around too. If you're going to have yourself tested, the question is, why jump to have your children tested even if something's found? Why not have your children still just receive a baseline test and be treated as though something was found? And I think that question comes up because of insurability for life insurance and stuff like that. So is it, do you feel it's very important to have the genetics done if you find something in yourself, or should they just be treated as if they have it anyway?
So if you have a gene change that's pathologic that caused an aneurysm or dissection, and especially if it's associated with other things, it can be incredibly valuable to have your children tested. But also you want to protect the children. So
Hmm.
you do, I really encourage people to get whole life insurance before they do the gene testing, because for a healthy young child, it's very inexpensive. And it's something that with any condition, you may or may not be able to get later. And, right now there are a lot of gene protection um, acts and insurance protections, but they may or may not hold over time,
Right.
right? So
Right.
we do want to be careful. At the same time, your primary need is to prevent sudden death,
Hmm.
right? So if you have a child with fragile vessels, you're better off knowing, in my opinion. So I would protect the child financially, but I would also protect the child physically. And
Right.
also, if you have a child that may be free and clear, right, that's a
Hmm.
different perspective than having to go for all these screenings, care,
Sure.
worry. Do you restrict their sports? What do you do? Here, if you actually have a gene change that's known, you will know if they have it or not. The other
Hmm.
thing that you can do that wasn't available before but is available now is embryo or egg screening. So,
Okay.
say you're a woman who's pregnancy age, who has decided that despite some increased risk, you're going to do a pregnancy, or you're going to have a surrogate and do a pregnancy.
Hmm.
You could actually donate your own eggs to yourself and have them screened for your gene.
Okay.
And you could use your eggs that don't have the gene to to use artificial insemination for yourself or somebody else. For men, it's harder because you can't just do sperm screening. There's too many of them,
Hmm.
and you really don't know which one is going to go into the egg.
Yeah.
So you really can't do it, but you can do embryo screening. So there's obviously political and religious
Hmm.
thoughts about that, but it's available, and you could actually screen out the pathologic gene, but still screen in everything else about you as a human being.
That's
Um,
amazing.
it's amazing. So that's
Yeah.
a reason, like, especially if you have children, they would have that ability to use that knowledge to do this, and you didn't have the chance to do that, but your kids would,
And at what
right?
age would you do that testing? What would
It
be the
depends
earliest
on
age?
the gene. So,
Okay.
what age does the gene really usually show up? How pathologic is it? What else does it affect? Is your child actually demonstrating problems?
Hmm.
Or say your child is on track to be a really competitive athlete or football player.
Hmm.
Do you want to know if they have fragile vessels because you
Yeah.
have this gene in the family? So you may want to know young so that you could guide them into less contact sports. They could still use their athleticism, but maybe not in the contact sports or the powerlifting, or maybe their
Right.
training is very different. Or maybe they really should be restricted so that they don't have an emergency like you did.
Right.
Um,
And I would think just the education alone, I mean, and I don't really know all the problems that come with somebody with Marfan or Turner syndrome or ACTA2. I just know the names of these, but I don't really know all of the things that symptoms and the things that can go with it. But if you knew, then if your child comes to you to tell you they're having problems with their vision and you already know that they have, let's say, Marfan, well, now it's a different type of doctor's appointment. You're not starting from scratch to figure out what it is.
right,
Now you know, well, my child has Marfan and they're complaining about their vision. I
right.
would think it would go very differently.
Right, and I can tell you some mistakes I've made in, just as it's gene testing's been developed. So when I was a fellow a long, long time ago, it took 2 years to get gene testing. We sent it to this one wonderful researcher in Texas. It would take 1 or 2 years to come back. They were testing 4 genes,
Hmm.
and you may or may not ever get results. But if you got results, everybody was excited and interested, but you were
Yeah.
2 years out.
Right.
Now
Right.
you can test the whole panel of, usually around 40 or 50 genes. Takes about 2 weeks. It's a saliva sample, not
Yeah.
even a blood sample. And it's very available and it's very cost effective. So even without insurance, they'll cap the price usually at $250, because of the next gen sequencing. So it used to be around $6,000 or $7,000.
Mm.
So I have one girl in particular, woman who had an aneurysm. She also had lupus. And she actually was very fragile in surgery, had a moderate brainstem stroke at surgery, had her whole arch replaced, had an aneurysm show up where the clamp was for surgery that we were following.
Hmm.
And over about 5 or 6 years, saw, because I was following this clamp site that actually got better, saw a different area start dilating. Um, and, at that point, I said, we don't usually see this with lupus, like maybe the ascending aneurysm around your valve. You were in a flare when that started, but
Hmm.
recently that's been well controlled. We're seeing a whole nother area. We don't really have a family history, but why don't we do the testing? So she actually had a very rare genetic variant called an FNLA mutation. The variant that she had is almost always lethal in utero in men, but both of her parents are living, so we tested her mom and dad. Her dad was negative, her mom was positive. Her mom had a 5.5 centimeter aneurysm in the chest, and this is a really virulent gene that usually tears before that.
Hmm.
And her mom ended up having aortic surgery and before she dissected, only because the daughter had gene testing. Now, the daughter's daughter, who looked exactly like her, like if you painted a picture of one, the other showed up, in your mind,
Yeah.
did not have the gene. So it's not,
Right.
it does not track with the appearance of somebody.
Right. Right.
So just so you know, you can't say, well, that one's my mini me and that one's not, so I'm only going
Yeah.
to test that one.
Right.
Like
You
you,
have to
you
test
definitely don't
everybody.
want to do that
Yeah.
because it doesn't correlate at all. So her daughter was negative, and it turns out her mom had actually had a couple of miscarriages, and one she knew was a boy. Um, don't know if that's related, but we think so. So, fascinating
Hmm.
that, I was kind of duped by the lupus, even me, who loves
Hmm.
genes and loves figuring these things out, duped by the lupus into just kind of not doing that type of testing or not looking at other people unless they had the connective tissue problems, and we would have missed her mom.
Yeah.
So this
Yeah.
saved her mom's life by far.
That's
Um,
amazing.
hmm
That is amazing. And to your point, you had mentioned research versus clinical. We talk about this in the community a lot. There is a research organization, and for that, that's free,
hmm
and that all of that is typically nobody's going to find out the results of your research study. You don't have to really worry about insurance. But you're right. You will only find out if it shows something, and it could take a while for the batch of 100 minimum before they begin testing. So that is something to take into consideration. Whereas clinical, I mean, you usually get these results back very quickly. And I'm so shocked to see how much the price has come down, even just in the last 8 years since my event happened. And it is comprehensive, same comprehensive testing that goes on, but at least it's quicker, and you'll know right away if you're somebody that wants those answers right away versus waiting and you don't know how long you're waiting, which can be very frustrating.
But we do like everyone getting tested,
Yeah.
sisters, brothers, parents, kids. Everybody should actually have genetic counseling because they need counseling to understand if they get a negative test, it's fine. They didn't really need the counseling.
Yeah.
But if they get a positive test, it's all of a sudden, well, that was her, but now this is me.
Yeah.
And oh my God, what do I do with it? And I'm going to die, right? And, you need the pre-counseling so that there's an understanding and plan what to do with a positive test.
Right.
Right. So that it's constructive, so that it's used to improve screening, so that it's used to extend life, and not people aren't feeling like we're doing it to make them sick. Right. We're not trying to test a child to restrict them. We're trying to test a child to get them to a normal life expectancy.
Right. And you don't want them to have an emergency situation like I had.
Right.
You want to be monitored and followed. You want them to do what they can do that's in their control to be as healthy as they can be properly monitored and followed up. And then in the event something happens that's out of your control, because as you've said to me before, we are humans, don't forget that.
Right.
Then we can have something scheduled and have a scheduled intervention versus something emergent. Absolutely.
Right.
Now,
Yes,
once
and
you
again,
go ahead.
if someone's been part of like the Ritter, testing, if they know their gene, that can be used clinically for their care. Right. And that's wonderful. It's when the genes are negative that we really look at like exome sequencing or family, really putting families together, trying to understand what some of the other genes are doing. So of people that have the known genes, we understand a little bit more from other families now. What else to look at? Do we look at skin? Is their skin healing normal? Do they have clotting factor abnormalities? Like what else does this particular gene affect? But for people that don't have a known gene, there probably are changes in the fabric of the tissue that we need to understand better that we just haven't found yet. And that's where like looking at whole families or whole gene exome sequencing can make all the difference in the world. And if you have a family where multiple people are affected and the gene isn't found, like we definitely can find researchers that are interested now in trying to figure out the fabric of your family if you want that figured out so that it can be done in a constructive way. And again, hopefully that can be translated into therapies as they're available.
So if somebody had testing and it comes back of unknown origin, or I forgot how you term
Negative.
that. Just negative.
Yeah.
I don't have an answer. Something happened, but we don't know. Something may have occurred in more than one family member, but we still just don't know.
Well, it's more of the genes that were tested, all of them were normal.
So how long do you wait before you go back again? Or do you just go right to whole genome sequencing or testing?
I guess, again, it would matter on the person. Who else does it affect? So if the person has no family, you may not want to go that far. If you have 9 or 10 children, it would certainly help to have the gene to know who to check. So one person that we saw recently, had a gene for Loeys Dietz, but he actually has a lot of children and 8 or 9 siblings. And one of the siblings has 9 children.
Jeez.
So you really want to do, and that's why we say, we want to test the incident person, and then we want to branch out from there. So if you can, for example, test the parents, you only need to test the side of the parent that has the gene. Or if both parents are negative for the gene, right, they're either the wrong parents or the person that had the dissection is the first person that had a change in the gene, because our genes are evolving, right? And you could be the first person that has the change. But then also, like if your parents are negative, they didn't give it to your brothers and sisters. Right? So your brothers and sisters don't need to get tested, and neither do their kids.
Right.
And again, the value of a negative test in somebody that's related to someone with a dissection is really wonderful.
Mm-hmm.
You're really home free. You need to worry about them, but you don't need to worry about you having the same course. That's
Yeah.
just not your health history.
Right. Right. Exactly. So, if you wanted to give a brief explanation or help people understand some of the more well-known um, conditions that exist, where do you want to start with that? You want to start with Marfan, because these are terminologies that the community members hear, but for a lot of us that don't have anything more negative, we don't really understand what that means. And I still think that even if you're somebody who has, you may not understand some of the others. So it's always nice to just have an understanding of what everybody's going through.
Sure. So maybe we'll start with something called a TGF beta gene. A
Okay.
TGF beta gene is usually a gene that can affect the fabric of the vessels and make the vessels weaker, specifically the chest vessels. But there are no other skeletal issues with that. So it's somebody who doesn't have any unusual features, but had this happen, may have other family members where this has happened. And again, this is something that generally affects the thoracic aorta. There are different genes that can affect other vessels in the body, but for the most part, it's only thoracic. So it isolates the problem and screening to that area. And it would mean if we test the gene and you don't have it, you're fine. But if you have it, the screening would be all chest thoracic care.
Okay.
If you look at a gene like Marfan's, which affects the fibrillin gene, fibrillin is a gene product. This is one of the better understood ones. Abraham Lincoln would be one of the classic, like best descriptions. Or if you're going to draw a picture of someone with Marfan's, you'd probably draw him
Mm-hmm.
because he's one of the most famous, maybe the most famous.
Mm-hmm.
One of the interesting things about Abraham Lincoln, if you look at pictures of him, because they only had slow photography, at the end of his life, his leg that is not the planted one, he always crossed his legs. The planted one is flat. The top one is always blurry because it was bouncing.
Okay.
And everything was bouncing to his heartbeat because he had severely leaky aortic valve. And one of the features of that is that you see the pulse. When it's really bad, you can actually hear and see the pulse because everything bobs.
Mm-hmm.
So Abraham Lincoln had that toward the end of his life because he had Marfan's and a dilated root and the valve was leaking around the root. But Marfan's often affects the lens of the eye, some features in the spine, some of the tissues around the lungs where you can actually have like a popped lung or a pneumothorax, it's called. Things like the tissues in the abdomen, and it can affect healing. So if somebody's doing suturing on somebody with Marfan's, they need to reinforce it differently. It needs to be kind of stronger enforcement so that you can actually have healing better. So
Okay.
that's actually really important. Ehlers-Danlos syndrome, for example, there are collagen mutation abnormalities. Those can affect the joints. So people can have hypermobility or joint laxity changes where they can sublux or move their joints different than other people. Some of the most flexible people may have those changes, and it sounds so good because they can reach over anything, stretch over anything, scratch anywhere.
Mm-hmm.
But at the same time, the vasculature and joint ligaments are looser or weaker so that you can also tear them easier. So the healing may be impaired. People may get skin changes when they're healing that look kind of like cigarette burns because it's a different healing. And it's more fragile. It can get injured easier. So for those patients, we also do screening of all of the different sites. So vascular Ehlers-Danlos is very different than hypermobile Ehlers-Danlos. Hypermobile Ehlers-Danlos means that you have hypermobility of the joints. There is an increase in the risk of dilation of the aorta, but not anywhere as near as often as people that have the vascular changes. So if you actually have the gene changes, your risk of aortic aneurysm or dissection, aneurysm in the brain or other places is much, much higher than if you don't have the gene changes. So the people without the gene changes, their risk is markedly lower. So the current recommendation for screening is about every 5 years for the aorta, and somebody with normal dimensions with hypermobile Ehlers-Danlos, but it's every year in someone with normal dimensions with the vascular types.
Okay.
And again, we look for different other things, like something called median arcuate ligament syndrome, where somebody may actually have a strap that can go over their celiac artery and they have trouble after eating. So there are some associated things that are rare in general, but may be common 10 or 20 or 30% in people that have the gene change. So it helps you branch out and look for certain things and know where to do the screening. I don't know if that answers the question.
hmm The other one I know we've heard about is Turner syndrome.
So Turner syndrome is different. Turner syndrome is a chromosomal change.
Okay.
And patients with Turner syndrome often have actually smaller aortas and sometimes have something called a coarctation of the aorta, which is an indentation or pinching of the aorta that can make the blood pressure very high. But their aortas are also more fragile and they can actually tear or dissect at smaller levels. So, for example, where somebody with a bicuspid aortic valve and aortic dilation, you may recommend repair at, say, 5.5 centimeters, depending on the person, their risk, the rate of change. Somebody with Turner syndrome, you're going to index to their body size, which is often smaller. They're often short stature and small body. So it may be a much lower number, like it may be a number around 4 or 4.2, where you would actually recommend a surgical intervention for someone with Turner syndrome. So very different, and that is a chromosomal change more than a gene change.
How do you test for that?
There are actually blood tests that can look at the chromosomes themselves and count them.
Okay. When it comes to inflammatory diseases, like you had mentioned, lupus, I guess Crohn's could fall into there, rheumatoid arthritis, ankylosing spondylitis. How much of a part do those factors contribute to aortic disease issues?
That's a great question. And we don't know the exact answer. Like, a lot of these things are emerging, and that is a good part of the research. But
hmm
any inflammatory change and steroids themselves and some of the medications used to treat them, there were looks at certainly antibiotics
hmm
that could affect the vasculature and tendons too, right? So the
hmm
fluoroquinolones specifically are thought to be able to affect which would be like Cipro or Levaquin, may affect the tendons in the ankles, the Achilles, and the vessels.
Yeah.
So certain inflammatory problems may have more use of these medications, which may be part or all or none of the factor. But
hmm
inflammation affects the vessels. It can cause atherosclerosis of the vessels, weakening of the vessels. So anything you can do to actually treat the underlying causes is going to limit your effect on the vessels. I do not think that there's a higher incidence of any of the known rheumatologic problems with the currently described gene changes. So, for example, except for one, Marfan's patients have a higher incidence of something called ankylosing spondylitis, which is a straightening of the spine and has some antibody changes.
hmm
Outside of that, I don't think there's any sort of inflammatory markers like a raised sedimentation rate or need for steroids that is associated with things like Ehlers-Danlos syndrome or the ACT2 genes. That it's a different process.
hmm
And just like Turner's is more chromosomal, there may be something else that's more metabolic. So there are
Yeah.
some.
I was wondering if it was more a byproduct because having obviously I have had Crohn's. I know there are a lot of people in the community that also have Crohn's that have had an aortic dissection from an aneurysm. There are people that have lupus, RA, and ankylosing spondylitis. So those are the ones that I've been hearing. We're talking thousands of people, and there's enough people that you start to think, wow, I'm seeing a lot of you with this. But statistically, I know it's not a lot in our small group, but it's becomes more than just a coincidence. It's becoming more of a pattern that we're seeing people pop up. And so that's when I wondered, well, if some people are living with inflammation markers in the 30s and higher, this is how they've lived for years. I have to wonder, if they're living like that and they're having high blood pressure, maybe because of some of the medications, or just they would have anyway, there's no way to know, is an aneurysm then a byproduct of having these high inflammation markers continuously,
Right. And
because
again,
you've had the
blood,
illness?
I wanna add in because you said the word blood pressure. Like blood pressure matters,
Yeah.
but blood pressure is not related to some of these things. A lot of our patients with Ehlers-Danlos or Marfan's have some of the lowest blood
Hmm.
pressures you've ever seen, or even drop their blood pressure when they're standing because they pool, the fluid pools in the looser veins.
Yeah.
So some people have very low blood pressures but still have aneurysms. So
Hmm.
I think the inflammatory question is independent of blood pressure.
Okay.
I don't think blood pressure is a part of that at all. I think
Right.
that, blood pressure, if it's higher, is going to be synergistic with that and another
Hmm.
reason to hurt the vessels.
Yeah.
But the inflammation itself is mean to the vessels. It makes a hostile environment,
Hmm.
and then it can do things like this, which is to cause an aneurysm. So this is a 3D printed model, of somebody's aorta in the belly that had an aneurysm from their CAT scan. It's the real size and shape. Um, and this is somebody who actually had surgery and then had a leak and then ended up getting a catheter. I mean, a catheter based stent and was having some leak or fracture around the stent. And if you can see, these are just magnets we stuck in, but otherwise it's the same size and shape of the patient's aorta that Dr. Jeff Hirsch printed from their 3D, um, from their CT scan. And this was actually used to help the talented vascular surgeon who was able to figure out where the side branches, you can see the stent is the size the vessel should be.
Hmm.
And it was leaking around it, dilating the wall, and the wall here is incredibly thin compared to this side, which is the normal size of the wall,
That's
right?
amazing.
So it's a thinned out, ballooned out aneurysm that was leaking around the stent. And then they were able to put another stent over where it was leaking. And
And
this
how does that
person was,
just goes employed endovascularly?
yeah, endovascularly. So,
And then
which
will
means through a
eventually,
catheter.
will that aneurysm, will the outside shell, basically that layer, will never shrink?
No, it's not going anywhere.
But it doesn't
You're just
matter if that outside, it won't rupture
right.
because
So if it's walled off and you have the stents go from the normal
yeah,
part to the normal part, then it's just an area around the tube and it's walled off.
and
But you
that's
have to
it.
make sure it's completely walled off because if there's a little leak around it, it'll keep expanding.
Right.
So that's what the surveillance is after something like a stent. So if
Yeah.
you've gotten a stent and you keep saying, well, they keep wanting to see me, do they just want to like have me do all these tests and pay for the tests? This is why we do it because
Hmm.
if there's any spot of leaking around it or the vessel changes more to have more leaking around it, then you could have tearing and end up like this person. Oops. Uh,
How does somebody not feel that in their belly? I mean, you would have to almost feel that.
no, you don't necessarily have to have
Really?
any symptoms. And if you do, it's
Wow.
usually back, radiating discomfort to the back.
Wow. It's
So
amazing.
this
It's so
is
big.
this is the dissection, just to give you a good understanding of what it, because dissection's a term that's hard to understand.
Hmm.
It's hard for students, it's hard for patients. Dissection means you took this vessel and somewhere it tore. So blood is actually making a whole false lumen. There's 3 layers of the wall and it's torn between 2 of the layers.
Okay.
So you actually make like a septated place, this is actually blood clot here where it's blue. We just colored it blue. But you can see actually this is the real lumen and this is the false lumen.
Is the false lumen typically larger than the true lumen?
It doesn't have to be, but
Okay.
it can be. And, that's kind of the dangerous place because, the false lumen at some points can clot off if you don't make sure flow is well established. And what matters the most is what vessels come off of here.
Mm-hmm.
Right. So if your kidney artery is like one side comes off of here and one side comes off of here, this is the side you're more worried about because it's just a sliver. So, the whole idea of do you fix it? Do you leave it alone? How do you fix it? Is really how do we keep everything getting good blood flow? And does it have secure good blood flow? Right.
And
So
do they typically, if you have a circle, does it typically dissect or can it dissect in any angle?
well, it'll dissect through the wall of the vessel.
Right.
Right. So it's going to dissect through the wall and then it'll spiral down.
Okay.
Generally follows a certain pattern as it goes around the aorta.
Mm-hmm. Mm-hmm.
But
And what
I
size,
think
where is that located where you're showing
this
us?
is actually up here, like
And is
right
that
here.
typical size or is that dilated?
This is a normal size. Like, so
Wow.
this would be somebody's normal size. It's not really dilated. It was dilated some here where it actually tore, and
Yeah.
this is the middle part of it.
It's amazing.
Yeah, and
That's amazing to actually get a chance to see it.
yeah, so this is the branch vessels, like as it goes around, and these are the vessels that go up to the brain. So
Amazing.
that you can kind of see what size it actually would be in a person.
Yeah.
But
when I see you, I'm going to touch that when I come see you. I want to touch
you are invited to.
Thank you. Thank you. I want to take a second and see if we have any questions real quick to check in.
We do. Let's say hello to Shock Orts. He says, thank you for being here. Tammy Warner has a question. Hello, Dr. Fisher. How often should someone be tested after having a dissection? The first genetic testing did not identify a gene.
So it also depends on how the repair has gone. So usually minimum every year. But again, if there's areas where we're worried about the blood flow, or somebody's having pain where we're worried about extension, or there's fragile kidneys and one of the kidneys comes off a less stable area, then you may want to do it much more. But minimum about every year.
I think she might also be asking if her first genetic test showed nothing. How
Yeah,
often?
that's what she's saying. When should you do the genetic testing? I'm sorry, Tammy.
Yeah.
I meant like screening. So I have to get back on our genetic plane. So it depends. So I would say that COVID really slowed us down in some of the changes. We're expecting rapid changes in the understanding of gene changes. But I would say over the past 2, 3, 4 years, the panels are very, very similar. We are reclassifying a lot of the variants. So if you had a variant, it'd be worth checking maybe every year, every 1 or 2 years to see if your variant has been classified as important or clear, pathologic or benign. But as far as redoing the testing, I would check with your doctor and see if the panel has changed from when you did it. So I've seen some people that we tested in like 2005 and had a lot of people that now have a positive test where we can identify the gene because the panels are so different, where we were testing 4 and then 8 and then 16 genes, and now we're in the 40s or 50s. So we have a lot more to offer, but if you had it done just a couple years ago, it's probably not very different.
Okay. Ryan R. says, I always tell families that life insurance is important, but not as important as a life that could be saved.
Exactly. And again, you can do things like whole life insurance. You can also do, privately purchased testing, right? Or potentially through companies or groups like Ritter, if they'll do family screening. I'm not sure if there's a program for that. I don't think there is right now, but there may be in the future. But you can do, there's a company called Prevention Genetics. You can actually do paid for genetic testing with them. So there are commercial companies coming out to do different things. But again, if you get a negative test, you're home free. If you get a positive test, you're probably going to want to share them with your provider.
Mm-hmm.
So you probably haven't saved yourself anything, right?
Okay.
And again, this is something that is life-threatening, that you would make changes. So my threshold for getting a test is, if it's abnormal, will I make changes?
Mm-hmm.
Right? Will I screen differently? Will I test differently? Will I recommend different sports or activities or lifestyles? You know, if it actually has impact, then it's a test that is probably worth doing. And here, you know, the whole point is to save lives. So thank you, Ryan. I feel the same way.
Yeah. In my personal situation, and I have no problem sharing, when we first started talking, you know, my father had an abdominal aneurysm. His mother detached her retinas. I detached my retinas in the 90s. I've had degenerative disc disease. I ended up having a dissection. I also had Crohn's disease. So we did testing for me, and it came back no answer, basically. But that wasn't good enough for me when it came to my son. So we immediately, you and we implemented the strategy. And how are we going to explain to a 15, 16-year-old young boy full of testosterone that it's not about how much you lift in gym class, it's about lowering that, understanding why, and doing more reps, which was challenging. I mean, I already didn't put him in football to begin with. I liked saving his brain. That's just my personal opinion. But he did other sports, but everything changed for me with him. And I just treated him as though there was a possibility something was there. And, you know, you monitor him. We stay in touch with that. He's on a regimen to get in better shape. And, you know, I do want to look again when there's more genes. I do want to know, because if there is something, I want him to know right as soon as possible. I do want him to be able to be aware, not hyper vigilant like I've become, but just aware of a different way that he could be healthy, a different way to live his lifestyle.
Well, and also understanding what some of these other genes do, you may want to have him get more frequent eye exams, right?
Mhm.
Have the eye doctor know that there's a retinal detachment history in the family.
Yeah.
And you may want to get more frequent eye exams.
I do.
Right?
I get them twice a year, and I have a retina exam every year, special exam.
So exactly. So that's something you wouldn't do did you not have that history. So
Correct.
you're using that in a constructive way, and we are trying to find the silver linings. We definitely are, and we should keep looking, because as we understand better, we really may have better therapies.
Right.
Yeah.
Okay, thank you.
Okay.
Catherine Norris has a question. I've done genetic testing and tested negative. I would like to have additional genetic testing done. Since genetic testing is now more reasonably priced, what additional testing would you suggest?
So I would suggest meeting with a genetics counselor. I mean, we're very fortunate where we are, where with Dr. Dietz, there's 4 actual aortopathy genetic counselors, and they work with all of the different companies and all of the different testing, and look at often whole gene exome sequencing. But that is something that is hard to get their insurance. They work very hard to deal with different insurances or different cost centers or different programs. So I would actually meet with a genetic counselor at an academic institution, and and actually have the discussion. Do your family tree. Look at yourself. So they will look at your tissues. Are you extra stretchy? How far does your skin stretch? Do you have a high Baton score? Do you have any of the Marfan's features? Do you have other family members that may have the features? Maybe you don't have the features, but your sister clearly has Marfan's and you had the dissection and you both have the same gene. So it's really important to actually try to streamline the testing by looking at you when your testing's negative and saying, what could we offer? So we now have these resources available. We should use them.
Thanks, Catherine.
Okay. When you pulled out the 3D printed things, Tammy Warner said, "So cool," and I said, "I know, right?"
I love
It is so
Tammy.
cool.
Carry on.
It is so cool. Any other questions, Josh?
Nope, carry on.
Okay, we're going to carry on because I have to hit this subject because so many people always ask this question. And we're just going to go off genetics, go off 3D modeling. We're going to go right into pings and pangs. We do it every time because every time we meet, there's a ton more community members who have joined. And we coined this the pings and pangs because whether you're newly into recovery or you've been diagnosed with an aneurysm and you're in that watch and wait full of a lot of anxiety, or you're years later, you are going to not necessarily know your body. Your body's now different, especially if you've had surgery. Sometimes once you've been given a diagnosis, things might maybe even appear differently. But let's focus on people who have had surgery, who've had a dissection, and now you're feeling a pain and you're a few weeks in. And I read these all the time, and I tell everybody, talk to your doctor. A blanketed statement, let your doctor know that you're having these pains. But we've had conversation and you've said to me, okay, can you replicate the pain? If you roll around, if you walk, if you take a gas X, like, does it go away? Because there's nothing more painful than gas that gets trapped in your shoulder blade and mimics the same pain that you felt radiating up into a body part. When you feel these little pings and pains that typically could be gas or muscular, what would be your advice other than notifying your doctor? When do you go to the ER? What people are so like, do I just go every time? Now there's COVID, do I not go? They don't, not too sure what to do.
So I like people to go through kind of an algorithm of self-assessment. And if at the end of that, over like a minute or so, you can't answer the question, then call your doctor and have them help you go through it. And if you can't reach them, then go through this. And if you can't tell, you just go in and get checked out. So better to get checked out than not get checked out. But for example, if you've just had surgery, right, you're going to have surgical pain. So if you have something that bothers you when you move or you touch it, or even if you haven't had surgery and you're rehabbing, or you're starting a new exercise program, or you just did all the leaves and you're sore from it, which, hopefully is all of us.
Right.
But basically, if you have an area that, you can touch and it hurts, that's going to be more muscular. If you move your shoulder and a certain level, it bothers you, it's okay to call it your shoulder, right? And you can do things like, Asper cream or Bengay or topical things. See if you can make it feel better. See if heat makes it feel better. But try to get rid of the discomfort if you can. If you have heartburn, like you ate, a taco and you're burning, try some milk, try antacids, try a little Pepsid AC. And if it goes right away, it's okay to call that heartburn. You're going to have heartburn once in a while. You're going to have all the things you had before, but you should be able to make them go away. So if it's something that you can't make it go away, or absolutely if it's associated with lightheadedness or heart racing, or breathlessness, or it radiates straight through to your back and you can't make it go away with your Pepsid AC, then you go right to the hospital, right?
Yes. Okay, the other question, blood pressure. Let's
Oh,
start.
wait, one more thing
Sorry.
with pings and
Yes.
pangs.
Pings
If
and
you
pangs.
have like anything that lasts a second or two, especially if it happens in different parts of the body, those are normal. Okay. So you only have to pay attention to a pain that lasts at least more than a minute.
Okay, that is good to know because we're going to because after surgery, you forget what was once normal. You're so just completely taken out of your element that you don't trust what is normal. And if it mimicked at all a pain that you had before, everybody becomes like, I need a minute. And I like when you talk about an algorithm, we take what you have told us, my husband and I, and we'll go through, we call it a systems check. So we start at the top, and I purposefully think about my body. And usually by the time I'm done, I start to feel a little bit better. So I've completely distracted myself and in turn grounded myself. But I think about it. I look at what time it is I start, and I always know where the gas X is or whatever it is I'm going to take, or the Tums. And obviously, having had Crohn's, even though I've been in remission, it adds an element of mystery there. But we just take a minute and assess. And there have been times where per your recommendation, we've gone into the ER because it's like, look, this isn't going away. This is something that feels different. But it's a figure out with your doctor what it is you need to check. And like you said, we always say there's nothing wrong with making sure that everything's all right. There isn't. And if it ends up that you went in because you had bad gas, then you went in because you had bad gas. It is what it is.
Right, exactly. And, again, because of your risk, you should be welcome to get that assessment.
Right.
Although
Exactly.
sometimes the scans are really hard to read. So it takes a long time because they need to send them out or get better readers or, or actually get the old studies to line them up side by side, which you want them to do.
Right.
You also want to try to make sure that you either have access to your imaging or that you try to go to the same places where they have access to your imaging. Because if you're going all over to different places and you can't line up the imaging, then you can't compare them directly.
Exactly.
Yeah.
And one more thing, because I don't want to keep you, because I'm so appreciative of the time that you give us. Let's talk about the blood pressure cuffs. People vacillate between wrist or arm. Do you have a preference? And if you don't, and we can use either or, should we find a difference in readings for any particular reason?
Strong difference because the wrist ones are not as reliable as the others.
Okay.
So the most reliable is going to be a digital arm blood pressure cuff. I usually recommend the ones that were written up in Consumer Guide, which were the CVS, Rite Aid, and Omron brands. Although most of them are reliable now. One of the most important parts is finding a cuff size that fits you. So, arms are different sizes, but also heights are different. And probably the most important thing, here's a cuff. I just happen to have one. But probably one of the most important things is that the length of the cuff is 3/4 of the size from your elbow to the shoulder of the upper part of the arm.
Okay.
So you're looking at the length compared to your arms. So this would be a perfect size for me, but if I had a really long arm, it would be too short.
Right.
And what that will do is it gives you a high diastolic blood pressure. So sometimes if that bottom number is unusually high, definitely think about the cuff fit. So it should just wrap around without popping, right? And it should be 3/4 of the size from the elbow to the arm. So they come as small adult, large adult, extra large adult. And a lot of that is also the length, right?
Never
People
thought
think
about
about their
that.
weight, but you also need to think about the length.
That's interesting. Can we bring our cuffs into our doctor's offices to make sure they're calibrated correctly?
Yeah, so anytime someone gets a new cuff, we like you to bring it in and just check it against the manual. So they check it with a manual and you want to check it against yours. Or if you have two cuffs, you can check them against each other, see if you're getting, and it should be within, say, 5 points. Because your blood pressure is moving. Your blood pressure should never just stay flat. You're alive, you should be reactive.
Right.
So people come in upset that they have like a range of blood pressure. And if it's a normal range, we're excited to see that they're not too blunted from their medicines and that they can actually do what they want to do.
And then when people take it, I've heard some people say you should take it 3 times consecutively, like 5 minutes apart, and then you're doing an average, or do you just need to just take it once?
I would take it just once and then take it at different time. And I like people to make a log time, date, pressure. And if anything's going on, like, if people only take it when they're upset or exercising or exhausted, then it's going to be a higher number than their average. The goal is to understand the range and treat the average.
Okay.
Right.
And the other thing that you had said, I didn't mean to cut you off, sorry, was, and I learned this from you, is unless you have another reason, you should check it on the arm when you've had a dissection. The arm that shows a higher number, that's the more accurate number of what's really going on in your body. And that would be the arm that you would check it on more consistently.
Yeah, absolutely. Because that's what your head and your heart are seeing.
Okay. And I thought that was so fascinating. So unless you have a problem due to lymph nodes or something else that prohibits you from checking on both, if you don't have that issue, you should check on both. And the higher one is the one that you go with from that day forward, which I never knew.
Right,
I used to, in the very beginning,
after the dissection, you should know if there's a difference or not.
Mm-hmm.
If there's a difference, it's always going to be there. If there's no difference, it shouldn't come. So if all of a sudden you have a big difference, that's something to get checked out.
In the beginning, and before I even knew this, before I discussed it with you, I would see difference and I would then just say, okay, well, it's got to be the low one. And it would put my mind at ease, not knowing the whole time that it was actually the higher one. So that was a major revelation. That was way in the very beginning. It was always different, and the higher one scared me. So I just mentally thought, well, it must be the lower one. And then I would only take it on that arm to make me feel better, which was not the thing to do. So I'm glad that you shared that. I think that surprised a lot of people, actually. I don't think that doing our blood pressures and taking them are things that are taught to us necessarily when we're going through recovery. So that's why this stuff is so important. It's very eye-opening. Yeah.
Yeah,
right,
but take your cuff into your doctor's,
Yes.
check the calibration, and then use it and keep a log. But do it like time, date, pressure, once in a while in the morning, once in a while in the evening. And then you'll have a good understanding of the range and the average and understand if it's actually okay or not. And that'll help you get good blood pressure control, but also not overdo it. And also sometimes you can just change the timing of your medicines rather than the actual meds or strength to cover the places where you're spiking.
And that's a whole other conversation we could have one day, where we've talked about medications, and I've had people in the community just hate the way that some meds make them feel. And I try to explain, you need to share this stuff, communicate, advocate for yourself, because there's so many different types of medications. And this is what you do. If you hear somebody complain about one, and they're not having a quality of life because they feel like a zombie, you can address that and say, well, let's try something else. And maybe there'll be a more positive change. So we're just always trying to help people with advocating and sharing the information with people that can make the change for them. So we'll get there. We'll talk about that another time too. And Josh, any other questions?
Catherine Norris wanted to chime in and say, Dr. Fisher, you were awesome. This is so informative.
Thank you. Thank you, Catherine.
All right, we're going to let you go so you can do what you do tonight, have dinner, whatever, and we will be talking with you soon. We're going to do this again early part of next year.
You know what I'm going to do tonight? I'm going to think aorta.
You should think aorta. I saw your posters behind you, which is wonderful. That's what we all do, right? And you will be part of our evening support group, our support group session that'll happen on the last Wednesday. It happens the last Wednesday of every month and the first Tuesday. This month, it's going to be the last Wednesday at 7 p.m. Eastern. There are links on our website where you can sign up to join, and registration is free, and we encourage everyone to do so. Please like and click subscribe at the bottom or top or sides, wherever it might be on your page. Hit the little bell so you'll know about the live events that we do moving forward. And we appreciate your comments and everybody joining with us. Thank you, Dr. Fisher, so much. We always appreciate you joining.
You're welcome. Bye.
And we'll talk to you soon. See ya.